welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Casey Minnis, Executive Director for MS Focus, and I'm joined today by Dr. Ted Brown, who will be talking to us about MS and spasticity. After a presentation from Dr. Brown, we'll open it up to your questions and comments. So now I'm delighted to introduce our speaker. Ted Brown is the Director of Neurorehabilitation at the MS Center of Evergreen Health Neuroscience Institute. He's been at the center since 2006. He attended medical school at Harvard University and did a clinical fellowship at the University of Washington. Dr. Brown is involved in clinical care and MS research. In his spare time, he enjoys jogging, listening to audiobooks, playing pinball, and driving his son around as a soccer dad. Dr. Brown, we're so pleased to have you to talk about spasticity today. We know it's a tough symptom for people to deal with, and this is much needed information. Thank you, and I'll turn it over to you.
Okay, well, thank you very much, Casey and the MS Foundation, and thank you, Bhavya, for your technical help on this too. The MS Foundation is a wonderful organization.
And driving his son around as a soccer dad. Dr. Brown, we're so.
Okay, so I'm getting a message that I am asked to speak louder. So I'm gonna just talk louder, okay, and hope that how's this? Is this okay for everybody? Okay, good, thank you. So I'm going to go ahead and share my screen at this point. Let's see how that goes. Okay, all right, so I hope everybody's seeing what I'm seeing. This is my topic, understanding and managing MS-related spasticity. I just want to thank the audience for joining us today. I hope this will be a worthwhile talk. Taking up some time from your first day of summer. It's beautiful weather here in the Seattle area, and I hope wherever you are that you're enjoying nice weather and looking forward to a really fun and warm summer with your family and loved ones. So let's march on into the discussion. Let's see, gotta see how I do this. Okay, well, these are my disclosures. I think I need to do maybe something a little different with, if you'll give me just a second, just wondering if I can change the format here to be my slide presentation format to be more full screen. There we go. Okay, so these are my disclosures. I don't think there are any that are really relevant to this talk. And these are the goals for today's talk. So first, I just want to say spasticity is sort of one of those more mysterious medical symptoms in general, and very important in understanding MS. I just read a really interesting book about World War II code breakers in the United Kingdom who were trying to break the Enigma coding system that the Germans were using, and it was essential to sort of the war effort. Well, that same term Enigma sort of applies to spasticity, and I would hope to be a code breaker for you a little bit today, just giving you a simple understanding of what we're talking about with spasticity. Many of you may have some spasticity, but then maybe a better understanding about what's really going on, what lies behind the symptom, and then we'll definitely charge into some treatments. And we sort of take a stepwise approach to treating spasticity, as I've indicated there, and we'll go into more details, but starting with holistic ways of managing it through exercise and stretching, and then working our way up the scale as needed to manage spasticity and keep it at bay. So the word spasticity, it sort of derives from a Greek word, spastikos, which means to tug. And spasticity, I think of tight muscles. And so that tug reference applies. And throughout my talk, you'll sort of see images of various scenarios where there's some pulling or tugging going on, just to give you something to look at while we're talking. So here's the short version. So if there's one slide that I'd like you to come away from this with, it's this. Okay, so when we talk about strength, of course, we mean muscles are doing basically what we want. We send a nervous signal to a muscle and it contracts. With weakness, the muscles don't do what we want. Well, with spasticity, the muscles do what we don't want, okay? So there is muscle action, but it's overaction. That, in a nutshell, is the nature of spasticity. You got it right there. Muscles doing what we don't want. Not muscles not working. That's paralysis or weakness, or you might see the word paresis. But this is overactive muscles not responding the way we want them to. Okay, that's the nature of spasticity. Okay, where does it come from? Well, it's an imbalance between excitatory stimuli to muscles and inhibitory stimuli, because actually this is going on constantly, that our muscles are receiving signals from the nervous system which are telling them to relax, and then there will be intermittently signals saying contract, and that's got to be in balance, and it's got to be timed properly. And in spasticity, those signals are out of control. They're not properly being generated and transmitted to muscles. Along with the problem with the signals to the muscles, we see exaggerated reflexes, increased muscle tone, and then I just want to point out that this is not specific to MS, although most of what I'm talking about is specific to MS, but we see spasticity in many other diseases. Too many for me to count, but some common ones are stroke, spinal cord injury, traumatic brain injury. Those are three of the big four, along with MS, let's say, but there are numerous other diseases that cause spasticity, and quite often they can sort of look the same, but we're going to focus more on MS spasticity. All right, on a pathophysiological basis, this is what's going on. This is a normal reflex loop. So we've got on the left side, we see someone's leg. We see a reflex hammer. The reflex hammer is tapping the knee. Well, what happens when you tap that patellar tendon just below the kneecap? It stretches the muscle. Now, the muscle have what are called stretch receptors, which send a signal up to the nervous system along a sensory pathway. That goes to the spinal cord. And on the right-hand side of the screen, we see a horizontal slice through a spinal cord to show sort of the reflex loop. So the sensory fibers, if you can see my cursor, the sensory fibers are going into the spinal cord, into the anterior horn cells, and then there's an automatic reflex loop sending a signal back to the muscles to contract. At the same time, it also sends signals up to the brain to say, hey, my knee just got tapped. I've just gotten a stimulus, and that takes a little bit longer actually than the reflex itself, but it wants your brain to be aware of what's just happened along the sensory pathway. And then it also sends a signal to the opposite leg. And with spasticity, you can tap one leg's reflex and you can get a contraction reflex on the opposite leg if there's an excess of reflexes, or hyperreflexia is the term that we use for that. Okay, so this is the way the system's supposed to work. And think of it like, let's say we look back at our great ancestors, and they're walking along in a field, and suddenly, there's a tiger chasing them down, and they start to run to get away from the tiger, right? Well, let's say there's a 3-inch hole in the field that they step down into, that they weren't looking at because they're probably looking over their shoulder at the tiger. Well, when they do that, what that does is it it creates an increased stress on the opposite leg that's having to compensate while the one leg is going down below the level that it was expected. That sends a reflex loop to the spinal cord, back to that leg that's being stressed, saying, strengthen up really strong so you don't just completely buckle and fall over. So that sort of reflex is essential from an evolutionary standpoint so that we can maintain normal function. We need our reflexes. But with spasticity, it's an excess of these reflexes. I hope everybody's got that basic idea that reflexes are essential to normal walking, normal function. We all need that, but too much of a good thing is bad. So now the scientific basis of spasticity is illustrated here, that on the left side, we're showing normal signals coming from the brain to inhibit reflexes, to keep them under control. We don't want to have too many reflexes. And these inhibitory signals modulate the reflex signals and the muscle tone to keep the muscle at a relatively relaxed level. We don't want the muscles to be tight all the time. Well, when there's damage to the brain or the spinal cord, then there's a reduction in these inhibitory signals, so that the muscle is expecting to get this inhibitory signal. It doesn't come, so it says, okay, then I'm going to get tighter and tighter because I'm not getting the signal to relax. So that's the basic issue here. So in MS spasticity, the inhibition of the signals is coming from demyelination, axonal damage, which can be at the brain level, at the brain stem, but more often is actually at the spinal cord level that there's demyelination. It can be at any of those levels, but usually it's going to be at the spinal cord level that's generating MS spasticity. But it can be at any of those levels. It's fairly common. In one North American, I'm forgetting all the words behind the NARCOMs, but it's a registry of MS patients. But in this one survey, 34% of all comers with MS reported spasticity. And spasticity is that's fairly common. It's more common than is reported for some other common symptoms like memory problems, bladder problems, or pain in MS. Clinical manifestations of spasticity include muscle stiffness, tightness, pain, cramps, although I saw there was a question earlier about, hey, are cramps the same thing as spasticity? Not necessarily. I'll try to get back to that in the Q&A part. But you can have cramps with spasticity. Involuntary movements, jerking, clonus is a repetitive spastic movement that we will see sometimes at people's ankles when we stretch the ankle and it starts bouncing up and down, and you see the heel moving up and down. Sometimes we see that at the knee as well, sometimes even at the arm. There is difficulty with movement. Usually that's because of the overactive muscles, the hypertonicity. Spasticity often accompanies other symptoms. I've got example given overactive bladder because the bladder sort of has some reflex mechanisms involved, and when there's damage to the nervous system causing spasticity, quite often we'll also see bladder dysfunction, numbness, weakness, difficulty walking, among others. And interestingly, spasticity, as those of you with it probably have noticed, it tends to fluctuate with MS. It's not a constant all the time. There might be good times, bad times. It can fluctuate from day to day, from season to season, and with certain triggers that can, when people are more fatigued, they might have more spasticity. When people take certain meds, of course, they can downregulate spasticity, but perhaps certain meds might trigger more spasticity potentially. And then environmental factors like dehydration, cold temperature can trigger more spasticity. Here's an interesting graph that shows the likelihood of having spasticity as the level of disability goes up. So the spasticity scale, many of you will not have heard of that, but that's just a way of grading how much spasticity there is. And here is sort of a simple display showing as we go from normal, no disability, across a scale to severe disability, we see that the rating of spasticity in MS does go up. And it makes sense. The more damage, the more likely there is to be spasticity. It's not always true. Some people with a lot of disability have no spasticity, but more commonly, we do see overactive muscles and spasticity. So factors contributing to spasticity, I alluded to this just a moment ago. They include pain, temperature changes. For a few patients, it's hot temperature that causes more spasticity, but more often it's cold that causes more spasticity. And I'm always reminded of an interesting study done in Colorado where they put MS patients in a cold tub to see what effect the cold chilling would have on their walking. And the hypothesis was that they'd put them in the cold tub, they'd get out of the tub and they'd walk better. But what they found was they put them in this cold tub, they brought down their body temperature. And when they had them walk, they were actually seeing as a group that the MS patients were walking poorer. And they hypothesized that what they were really seeing was that the cold temperature was making their spasticity worse. And so they were walking worse. Now, remember, these temperature effects do vary from patient to patient. So I'm not saying across the board. This is just sort of as a general rule, cold temperature tends to aggravate spasticity. And then fatigue, psychological factors, especially stress, will tend to worsen. You know, when people are stressed out, their muscle tone is going to be increased anyway. And that's going to tend to make spasticity worse. Other conditions, especially those which cause pain, like it could be an ingrown toenail, an infection, even a broken bone. I've had patients come in saying, gee, I'm really stiff, what's going on? And lo and behold, we find out that they've broken one of the bones in their legs and they weren't aware of that because they're using a wheelchair. And then certain medications, some patients will be on an interferon and they're taking those periodically, and we might find that their spasticity is worse after they've had their weekly or their every other day interferon treatment. How do we measure spasticity? Well, many different ways. This is a simple scale, but there are other ways. For research purposes, we might grade spasticity based on how often people are having spasms. A lot of people with spasticity don't have spasms. They're just stiff all the time. But some people do have spasms, and we could grade it like this, going up from 0 to 4. Then there's a questionnaire, quite detailed. There are different versions of this, but one that's commonly used for research trials is a 88-point spasticity rating system that someone would do by themselves. Obviously, we don't use this for clinical purposes because who's got time to go through 88 different questions to answer it? But for a research study on spasticity, this would be a useful scale to use, the MSSS 88. I think it's MS spasticity scale. And then what we commonly use, both clinically and for research studies, is something called the Ashworth scale, or the modified Ashworth scale is a newer variant, and that's measuring muscle tone. And we very simply will have an examiner move a joint through its range of motion at various rates, slowly and quickly. The spasticity tends to be brought out more when we do it quickly. And we're grading, is there normal muscle tone? Is there a slight resistance just briefly and then it lets up? Is there more mild resistance throughout range? Is there more strong resistance throughout range? Or is it so severe that you really can't move the muscle? It's just so locked in that you can't stretch it. So that's the Ashworth scale. And I've got a few slides later on that will show medication effects as measured with the Ashworth scale. Still in use today. And Dr. Ashworth was an English doctor who described this scale, just sort of made it up. And actually, here's an example of the Ashworth scale. So this is one of the drugs that we use. And this graph I really took just because it really demonstrates how we can use the Ashworth scale. So we have here just improvement in the Ashworth scale. So remember that 4 or 5 is sort of the top. Well, excuse me, on the Ashworth scale, it goes from 0 is normal to 4 is the worst. And this is improvement in the Ashworth scale with a composite of different muscles. And so we're seeing that after taking a anti-spasticity medication relative to a placebo, we can see that the drug does have an effect. In this case, it's tizanidine, which is approved for spasticity. It does have an effect, and that effect wears off over some hours. And we'll come back to tizanidine when we talk more about the medications we use to treat spasticity. Well, so then why treat spasticity? The main reason is because of all the negative aspects to spasticity, and those of you who have it are well aware of these things. So it can impact walking, it can impact standing, sitting, and transferring. If someone's not able to walk, in transferring, we might find that spasticity is causing them to have their legs interfere. In trying to transfer, their legs are getting in the way because the knees are out in extension, or they can't bend the knees properly or bend the hips properly. And in sitting, sometimes spasms can pull someone out of their chair. So those are the functional ways that spasticity can interfere. Now, when it's untreated, spasticity will lead to stiffness of the joint and ultimately contractures. And a contracture means that there's just a limit to the range of motion. You can't fully extend the joint all the way. It's stuck at some degree of contracture. And in MS, spasticity tends to be worse in the lower extremities than the upper extremities. We see contractures at the ankle. Usually the ankle is in a what's called plantar flexed position, and we can't fully dorsiflex or extend, lifting the foot up relative to the leg. We also see tight hamstrings, and we'll see knee flexion contractures that we can't fully extend the knee. But we can also see contractures at the hips and upper limb contractures as well. Spasticity can cause injury. People can injure themselves because of a spasm. They can break their toes. Sometimes spasms can injure a caregiver as well. They can kick a caregiver. In doing an exam, I get kicked once in a while when I'm testing someone's reflexes, and I don't get out of the way and get kicked. Spasticity can be painful, either from a quick spasm or just the discomfort of having really tight, uncomfortable muscles that won't relax normally. Spasticity can interfere with sleep because someone's uncomfortable, or because they keep having these muscle spasms, these jerks that keep them up at night. Spasticity can interfere with normal hygiene. It can make it harder for someone to change their clothes, harder for them to do toileting, harder for them to change position in bed, all of those things. Spasticity can interfere with quality of life as well because of all of these reasons given, and then impact the caregiver. Basically, the more spasticity, the more difficult it is to do ordinary activities of daily living, including changing clothes. Well, that being said, do we want to treat everybody with spasticity for spasticity? Not necessarily. To some extent, we always want to have some management, because when there's spasticity, you always need a range of motion stretching program. That's non-negotiable. You always need that. But in terms of medications or more involved treatments for spasticity, maybe not. Well, why not? It's because spasticity can have some positive impacts. People can sometimes make use of their spasticity. For one thing, spasticity is a way to hold a limb in an anti-gravity position. Some people can walk on their spasticity. So they're very weak, but their muscles are fairly rigid. And so if they can sort of work themselves up to a standing position and then sort of shift their weight and get a little bit of hip flexion, they can sort of stagger forward using a walker and sort of walk on their spasticity. Whereas if we took that away, they wouldn't be able to wait there. Same with standing. Some people cannot walk, but they can stand on their spasticity, and standing is good for you, basically. Standing helps to reduce bone demineralization. It's good for the circulatory system. Standing also is a way to treat spasticity, as we'll come back to that. And anybody who can stand wants to maintain their standing. So you have to bear that in mind when we treat spasticity, is we've got to watch these things and make sure that we're not compromising function, in order to treat the spasticity. Spasticity probably has a beneficial effect on the muscle bulk as opposed to muscle atrophy. When someone has an areflexic muscle, they've got no muscle tone to their muscle, and they can't use the muscle, that muscle will atrophy. If those muscle fibers are not getting stimulated, then they will atrophy. And spasticity, among the few good things that it does, it's sending these signals to the muscle saying contract, 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 and that can cause the muscle to maintain its normal muscle bulk, and actually can cause hypertrophy. I've seen some patients with spasticity come in and they've got larger muscles than normal because their muscles are working all the time. That's not really good. It's not going to help them to do more. But on the other hand, atrophy is definitely bad. And so spasticity sometimes has this positive attribute that it helps to maintain some muscle mass. And then it's possible with spasticity that there might be some secondary good things about it, in terms of if someone's fairly spastic in their legs, they're probably less likely to have a blood clot than if they're totally flaccid and they can't move that leg at all, because blood clots tend to occur in a flaccid limb. And then spasticity might help in terms of giving some stress to the bones, and therefore reducing the likelihood of progression of bone demineralization to osteoporosis. So in every case, we come up with this: do we treat or do we not treat? And it's an individualized decision. I would say, as a general rule, if the spasticity is noticeable enough for us to pick it up in the clinic, usually we're going to be wanting to treat it, but not always. There are some patients where, there is sort of, some functional side to this that we don't want to take that away. So it may not be so much a yes, treat versus no, don't treat, as it's sort of treating to a certain extent. How much do we want to treat? How strongly do we want to fight the spasticity? And this is the approach that we take. So really the rest of this talk, I'm going to be going through our algorithm about, where do we begin and where do we go? We go from there, sort of up the scale, because we always like to have a healthy, holistic approach without use of medications, if that's possible. If that's going to do it, then there's no need to get into medications, which can have side effects and have their expenses and their drug interactions as well. Okay, so what's at the foundation? Well, I said earlier that spasticity is worse when there's pain or anything that is sort of a stimulus that's irritating the nervous system. That triggers more spasticity. So we want to make sure that we're not missing something that's going on. When I have a patient contact me and say my spasticity has been worse for the last week, we're not going to just say, okay, well, here's what we need to do. We're going to ask questions like, well, how's your health been? Has anything been going on? Have you had any falls? Could there have been an injury that caused this? Could there be a bladder infection? Could there be a kidney stone? Could there be something else going on? Could it even be stress in their life that maybe they're going through some really stressful times, and we've got to bring that stress under control so that their spasticity will sort of recede as they're feeling more comfortable and relaxed. Okay, so that's the first thing is, are there some triggers that we can move? Sometimes it's even just like tight clothing. Someone might be, they might do better if you just sort of loosen things up, especially during the summer when it's hot, instead of having them wearing tight clothing that might be sort of uncomfortable for them. Then the next step is going to be stretching, exercises. Everybody needs that. Spasticity or no spasticity, MS or no MS. We really all need to have a stretching program. But when you've got spasticity, it's doubly important. You've got to have a stretching program. And that stretching program has to be done daily. It really has to be done daily. Why? Well, because when you stretch a muscle, so you're lengthening the muscle fibers out, but they're getting these signals from the central nervous system that are basically saying tighten up again. They're not getting the inhibitory signals to balance out with the excitatory signals. And that takes about a day. So if you stretch once a day, you can maintain a level of looseness in that muscle. But if you're only stretching once a week, that doesn't cut it. Then the person might be spending 6 days a week with a tight muscle and 1 day a week where they're relaxed. So a stretching program has to be done daily. It could be done twice a day. That's even better. But we sort of aim for once a day because we want to make it sustainable. And so the more people try to do 2 times a day or 3 times a day, I think the more likely they are to sort of not stick with it. But once a day, I think, is a good goal to try to do a stretching program once a day and stick with it, okay? These are some of the non-pharmacological treatments that we do. Before I've got a few slides on stretching, but I want to address these other things. So we mentioned about addressing contributing factors. I didn't mention about optimizing sleep, staying well hydrated, having good positioning. For somebody who's non-ambulatory, when they go to bed, we want to make sure that they're positioned comfortably and they're changing position as possible. With a very stiff spastic joint, we might need continuous stretching to stretch out that joint. We call those braces orthotics, is a medical term for bracing. Very commonly, that means bracing at the ankle to keep the ankle from always being where the toes are down relative to the position of the leg. And then stretching and exercise, and then physical therapy. Physical therapy is very helpful to go through a stretching program and individualize the stretching program. But physical therapy can offer other things to manage spasticity, including muscle massage. Just manually working the muscles will help to break up that muscle tone, relax the muscles, and relieve spasticity. And then force use is sort of, some people will have weakness and they're maybe not using their limb as optimally as possible. But with the right exercises, you can gain more function and use of a weakened limb. And then heat and cold, well, most often it's not cold therapy to manage spasticity. We don't usually want to overheat people either, but we sort of look at that, and because it is individualized, we might use heat to relax a very tight muscle, and conceivably use cold, especially if there's inflammation. And then weight bearing. So here we have a person who is standing at a standing frame. She uses a wheelchair. She is not able to walk, but she's standing at a standing platform, and she'll do that for 20 or 30 minutes. And that gives the legs a really good stretch, as we talked about earlier. Standing platforms can possibly be covered by insurance, not always, but what I would recommend is if you're not able to walk and you have difficulty standing on your own, you might check with a physical therapist and see if they have a standing platform that you can try out and see how you like it, see how it goes, and then try to get a standing platform in your home that you can use for 20 or 30 minutes every day. It's best really to start doing this process with a physical therapist if you haven't been standing recently, because if we use this otherwise, someone might get dizziness from getting up to a standing position when they're not used to standing. Physical activity itself helps to manage spasticity. Here is a study of MS patients, 27 MS patients with mild or moderate disability. They had them simply do a 20-minute exercise bike activity versus just sitting in a chair doing nothing. They measured hypertonicity, that's the amount of muscle tension in the legs, and then they measured the spastic reflex loop using that modified Ashworth scale. That's the MAS that I talked about, the muscle tone scale, and then an electrical test called an H-reflect. And this is what they found, that on the Ashworth scale, you can see that before the exercise, they were about the same level, the people who were randomized to cycling versus those who were the control. And then sitting down for 20 minutes versus 20 minutes of cycling, we see at 10 minutes after, the cyclers have a lower level of muscle tone, and that this persisted, although their tone is sort of gradually coming up, but that difference lasts for a full hour between where they were at versus the unexercised group. All right, so some stretches. Well, spasticity is usually worse in the legs, and so the stretching program in MS is usually focused on keeping the legs loose. So we start with the hips, and here's a couple of exercises. You can do sort of hip abduction, or a sort of a frog leg type of stretch. Hip flexion exercises are important. So you're trying to bring the knee up to the chest, and perhaps maybe crossing over to the opposite side when you do so. Like towards the opposite shoulder will give you even more of a stretch. And then the bottom right corner, while the man is bringing his knee up, he's also letting the opposite leg hang down. So that's stretching the hip flexors on the opposite side. And then calf muscle stretches. These are really important. And for most people, that's going to be getting done standing. And there's some basic ways of doing it. You're pushing against a wall, you're pushing against a chair, something stationary while you're stretching the knee. And you want to do it two ways. First, you want the knee straight, and then you want the knee flexed, because here you're going to be stretching the upper calf muscles called the gastrocnemius. And with the knee bent, you're going to get a deeper stretch lower down in these deeper muscles called the soleus. Okay, so do the stretch both with the knee straight and with the knee bent, and try to get that heel down to the floor as close as you can, and do it for 30 seconds or 60 seconds in both positions, then switch to the other side. Okay, a more advanced way that should only be done when someone has something to hold on to would be like using a stair, and here this person is actually stretching their calf muscles beyond that neutral position. They're going into a more dorsiflex position, but again, you've got to do that with support. We don't want anyone falling over. when they're doing a stretch. And then this passive technique is someone that someone else would do. Perhaps if someone's unable, they don't have the hand function, or they're not able to reach their calves to do it themselves. This is one way of getting a passive stretch, okay? Then hamstrings. Hamstrings are really important too. So simple way of doing it is just to have one leg with the knee straight out in front of you. It can be done up on a sort of exercise bench like the woman on the left is doing, or it can be done with one leg down on the floor and the other leg on a chair in front of you. And then you sort of stretch forward as you're able to. On the right, we're seeing that they're using a towel around their feet and then pulling themselves forward. So you're getting a little bit of a back stretch, and you're getting a hamstring stretch, and you're also stretching the calf muscles at the same time, okay? And then just as sort of a joke here, I've got advanced stretches here. I wish I was like this older woman here who's got such great flexibility in her hamstrings. But this would be the woman on the right, right lower. That's a really good stretch for a pretty flexible person, which I wish I could do that as well. For many people, when you're beginning, don't try to stretch the hamstrings on both sides at the same time. Just stretch one leg at a time. So perhaps up on a chair. All right, now we're getting into the medications. So again, I just want to emphasize that we don't start with the medications. That comes after we've done all the sort of groundwork of making sure that we've got the right habits, we've got the stretching program, and then if that's not enough, then we go to the anti-spasticity medications. So we use it when it counts, use it sparingly, don't use too much of it, because these anti-spasticity medications do cause side effects. All of them are short acting. There are ways that we can have longer acting, but the oral medications are all short acting. There are some new long acting versions, but they're not in common use. So here's what we use. The most common three are baclofen, tizanidine, and gabapentin down there at the bottom. Gabapentin is actually not approved for spasticity. So I just want to say that's an off-label indication, but baclofen and tizanidine are used for that purpose. They're a little bit different. I'll come back to them. And then dantrolene, we seldom use in MS. Benzodiazepines is Valium and clonazepam are a couple of examples of that. Okay, now all of these medications can be combined with MS drugs. We do have to watch out because these can be sedating, and some other MS symptom drugs can be sedating, but these medications can be combined with virtually all of the approved MS drugs. Okay, just want you to know that. General considerations. Okay, most of these cause sedation to more or lesser extent, but it's always something we have to watch out for with every single one of those oral drugs that I just mentioned. We always start low and we gradually increase the dose as needed. It's a mistake if we start at a higher dose and then we just sort of knock someone out and they say, well, I didn't tolerate that medication. And yet if we had started lower and gradually sort of ramped it up, we might have been able to find that sort of right therapeutic window where we're treating the spasticity, but we're not over treating and making the person too sleepy. So we slowly titrate up. Now the effective dose is where we're going to stop. If we're not sure we're there, and they say, well, I've still got spasticity, we might just keep inching up until we say, well, higher dose isn't helping, or if we're running into side effects. And most commonly, that's going to be drowsiness. We can combine medications. Sometimes someone doesn't tolerate anti-spasticity at a higher dose, so we might back off and then possibly add a second anti-spasticity medication and find that they're able to tolerate the two medications in combination with less side effects than if we just use one medication alone. I want to mention that all those medications that I alluded to, they are all generic now. None of them are really expensive drugs. Okay, more on baclofen, because that's the one we use most commonly. It acts at the spinal cord. So even if spasticity is caused by a brain lesion, baclofen can still work. It does work at the spinal cord. It activates gamma aminobutyric acid 1B receptors. But that's where it's working. It's been shown to work in spasticity. We're very confident that it really does have an effect. It's not that long acting. So when people have a lot of spasticity and they take this, they're going to have to take it 3 or 4, perhaps 2 times a day. Particularly effective when spinal cord is involved. And there's that dose range, pretty broad dose range, usually between 10 and 80 milligrams per day, sometimes higher, although that would be off-label. And weakness is actually the #1 side effect with baclofen, more so than drowsiness, but it can cause drowsiness. And then tizanidine. This works at the brain and spinal cord level. It has been shown to work in spinal cord injury, but it's approved for spasticity in general, and we use it in MS. It may cause less weakness than baclofen, but it's definitely, as a rule, more sedating, and it can also cause dry mouth and probably drop the blood pressure a little bit. And there's the dose range that we use, but this is a medication we often start at bedtime since it does tend to make someone sleepy. Sometimes that might be a side benefit, that it makes them sleepy. And then I'll just very quickly mention these other drugs. Don't use dantrolene much because it can be hepatotoxic. Diazepam and clonazepam and other benzodiazepines do relax muscles, but they cause quite a bit of drowsiness. They can cause dependency as well. And then gabapentin probably isn't quite as effective, but there might be patients who have both pain and spasticity, and sometimes the gabapentin is useful for both of those. Complementary and alternative treatments. Here are some things. Acupuncture might be helpful, but I don't know that it would last a whole week. Visualization techniques where you're sort of imagining relaxation of your tight muscles. Biofeedback can be helpful. Low-dose naltrexone may have an effect. That's an off-label use. And then cannabinoids. Here are some products. Sativex is not approved in the United States. And there's medical marijuana. I'm just going to mention in this slide that this is a study of cannabinoids. It's a smoked cannabinoid treatment, which we generally do not recommend. We usually recommend CBD products relative to THC, but you can see here that there is an effect. The patients either got placebo or they got the cannabinoid, and the placebos, their spasticity score on the Athrower scale didn't really change. Whereas those who got the cannabinoids, you could see that there was a reduction in the spasticity ratings. But cannabinoids can have side effects. And so always talk to your doctor before getting into that. You know, it would just be a mistake to just go out and experiment without checking with your team, because they would want to give you some counseling, and it's not the right approach for many people. And I'm not really advocating that in general as a spasticity management. Now, a warning about spasticity meds: if you stop abruptly, you can get rebound spasticity, and it can be quite bad. That's true with baclofen, tizanidine, and benzodiazepines, including Valium, okay? So we usually taper spasticity drugs instead of dropping them abruptly. And it's important when you go on vacation, if you're taking a spasticity med at a moderate or a high amount per day, that you don't forget to take your meds along with you, because you can go into withdrawal and get sick. You can get a fever. You can get really spastic. It can be bad. All right, then botulinum toxin. This is a targeted treatment. I think you're all familiar with Botox, which is one of the botulinum toxin products. There's different agents, and all of these actually work at the neuromuscular junction to block that and relax the muscle. They block the transmission of acetylcholine from the presynaptic terminal to the postsynaptic terminal at the neuromuscular junction. We do injections into targeted muscles. It takes a few days to kick in. it sort of peaks at a few weeks, but the effect will last for at least 3 months in most cases. It can have side effects, including local pain. We can overtreat, and then you might have muscle weakness. And if you do it repeatedly, you can have muscle atrophy. This is an expensive treatment, so it's important to check coverage. We don't want out-of-pocket expense surprises. So if someone's going to start on Botox treatment, or excuse me, any botulinum toxin treatment, because there are different agents, we want to make sure that the insurance company is contacted, and you're asking, what's my out-of-pocket expense? Not just is it covered or not, but what is going to be my out-of-pocket cost for this? And this is sort of what they look like. They come in vials. They might be a powder that you add a diluent, or they might come in a liquid form, and we inject directly into the muscle. Then surgical treatments is another step up. We don't use that very often. Sometimes there'll be a tendon lengthening procedure, like an Achilles tendon lengthening. They are effective, but we usually find other methods more effective. So in our adult MS populations, there's not much of a role for surgical treatment, although I do try to keep that in mind, because there might be patients for whom that is a good answer. For example, someone with a very tight clawed hand, where we've tried other ways to relieve that, and they've got quite a contracture, tendon lengthening procedure might be the best approach in that situation. And then there's intrathecal baclofen. So this is the last of the interventions that I'm going to talk about. This is FDA approved for severe spasticity from cerebral or spinal origin. So it includes spinal cord injury, potentially stroke, and multiple sclerosis. It is a device with a chamber inside, into which baclofen is injected through the abdominal wall into this chamber that is implanted, and then that catheter we see goes all the way up to the spinal canal, and it is continuously pumping baclofen into the spinal canal at a low rate. And the advantage of that is that we can give the spinal canal exposure to a much higher dose without getting some of the side effects from oral spasticity, since the brain is not seeing the same high dose. So we use this for severe spasticity, not for mild spasticity. Patients who are unresponsive to oral baclofen or other agents, but typically involves a screening test where we inject liquid baclofen into the spinal canal and see, does it relieve their spasticity? And if so, then that would tell us that they might be a good candidate for intrathecal baclofen. These pumps need to be changed every 5 to 10 years now. They're getting newer and newer technology. Some of the newest ones, you can adjust the rate of baclofen during the day, which is an amazing thing, that you can kind of self-adjust it just like a insulin pump. So again, it's implanted subcutaneously, it's programmable. These baclofen pumps are MRI compatible, but you just need to check with the MRI center. Refillable reservoir, intraspinal catheter. The catheter can be threaded higher up to control upper extremity spasticity. We don't do that too often in MS, but the drug administered this way does not reach the brain, which is an advantage. Even so, there are some side effects. That'll be the next slide after this. So benefits, potentially fewer side effects. It is a stronger way to administer baclofen, and it can spare those side effects like cognitive sedation and such. The programmable aspect of it is nice. We can see functional gains. That means that someone actually can potentially walk better. We don't see that too often, but we can see it. And then we can adjust the dose, because over time, someone's spasticity might go down, someone's spasticity might go up, and we can reprogram the pump according to need. Most common side effects are flaccidity. So we go from being stiff and spastic to being flaccid. and we can adjust the pump accordingly if that happens. It can still cause drowsiness. It can cause nausea, vomiting, headaches, dizziness, and there can be complications if the pump malfunctions, or even potentially the catheter becomes dislodged. That can happen. It does lower the seizure threshold as well. And then one thing to know, just these baclofen pumps, you can't go scuba diving. I think you can go snorkeling, but you can't go deep under the water if you were going to. Sorry to say that. All right, so I've talked about what is spasticity. I hope that you got the basics of that, sort of what are the manifestations in MS, and then this sort of paradigm of we start with simple management strategies and we work our way up the scale as needed. It's very important when you've got spasticity to work with your medical team, because there's a lot we can do that might include getting physical therapy involved. It might include medications, but it's really good to work together with your medical team on that. So that concludes my slides, and I'm happy to take questions. There's my last slide. I'm sure you're as elated as I am to be through.
Oh, thank you so much, Dr. Brown. All right, so we are ready for questions. We already have quite a few in the Q&A and a few in the chat. I'd also like to mention that if anyone would like to ask their question live, you can use the raise hand button. If possible, do try and send your question in the Q&A, because that will allow you to enter it anonymously if you so choose, and it makes it a little bit easier for us to keep track of. All right, so let's get started. Our first question in the Q&A is an anonymous attendee who says, I have issues with sphincter muscle spasticity. Is this common for people with MS?
Yes, unfortunately it is. So there's a couple of different sphincters that could be involved. It could be the bladder sphincter, or it could be the anal sphincter. It could be both that are involved. So, there's sort of two sides to that. On the one, there could be a hyperactive sphincter. So then that could be either difficulty voiding urine or difficulty defecating if it's the bowels. Or on the other hand, there could be a ineffective or hypoactive sphincter. That's not spasticity. And then you'd have incontinence in either direction or both. So yes, we do see we do see problems with a overactive sphincter, which can cause difficulty initiating voiding or initiating defecation, can make it painful as well. And we have various approaches to manage that. I hope that's answered your question.
All right, our next question is from Jillian from Facebook. She asks, why does spasticity always seem worse at night? It's affecting my sleep.
Well, there could be a couple of reasons there. One is maybe a person at night is trying to relax and they're trying to just let their muscles go. And so a person will be more conscious that, I don't feel relaxed. I don't feel like my muscles are moving easier. Also at night, that's when people are stretching out, right? They've been sort of upright on their feet, or if they're in a wheelchair, they've been sitting all day. And at night, they're trying to just let their joints sort of loosen up and straighten out. And so they feel that tightness. There could be other factors involved. It could be that that someone has an exercise program with stretches in the morning, and throughout the day, they're gradually getting stiffer and stiffer, and they need to maybe then have their stretches at night or stretches twice a day. Or perhaps there is a need for a medication to be dosed at night to manage that. I can tell you that our patients who are taking a spasticity medication once a day, most commonly it is at night, because that's quite often when spasticity is most problematic, is at nighttime, somebody's trying to sleep and their muscles feel tight and are spasming, and that bothers them.
Our next question is from an anonymous attendee, and it says, does spasticity in the neck cause a popping or cracking sound when the neck is moved?
Good question. I think more likely that would be some arthritis. Spasticity could, we don't see a lot of spasticity in the neck, first of all, but tight muscles certainly could make a popping sound in the neck, but more often that involves some of the joints in the neck creating that popping sound. It's still important for the neck to get a range of motion program, and I'll just say very quickly that what you'll want to do is you'll want to have the different planes of motion go slowly, extension, flexion, back and forth, and then side rotation, slowly back and forth, and then side rotation. If you can, bring your ear all the way to your shoulder, back and forth. But that's a good stretch for neck tightness.
Our next question is from Elizabeth. She says, what is the best type of stretching for spasticity, dynamic or static? If static, how long to hold the stretch?
Okay, well, great question. And you might get a very good answer from a physical therapist, but let's just talk about, I didn't really get into dynamic stretching versus static stretching, but I'll tell you what my conception is of that. So dynamic stretching, you're maybe stretching and relaxing it with repetitive stretches, whereas static stretching would be a prolonged, maintained stretch. For example, you could do that with just one stretch that you hold for a longer period of time, or you could do that with a brace, for example. So you put on a ankle foot brace that's holding the ankle in a neutral position to get a prolonged static stretch. And I think there might be some controversy about that. I think that either dynamic or static stretching could be effective. I think I'm a little bit more worried about injury happening with dynamic stretching if it's like a lot of sort of lunging and bobbing back and forth to stretch. But I would say here, if you're not sure what's the best way to stretch for you, try to get in with a physical therapist or talk to your doctor about this, and you can get more advice.
Our next question is from Coy, who says, if an MS patient has new contracture of the knees stuck in the fetal position for about 3 to 4 months, can this be reversed? If so, what are some ways to do so? Physical therapy is not helping much at all.
Okay. Well, I'm glad that you're trying physical therapy, because by itself, it may not be enough, but it's essential. It's an essential part of that. That can be very difficult. So it sounds like there is a contracture, maybe bilateral contractures, meaning that the knee cannot be fully extended. And when those knees get very tight in flexion, it's really difficult to stretch them out. So that might take a multidisciplinary approach. You might have the physical therapist working with stretching in the clinic and giving stretches to do at home, combined with the doctor perhaps administering botulinum toxin, or sending you to a specialist who does botulinum toxin. I just met with a doctor who does there are only 2 spasticity clinics in the whole country where they just do spasticity management, and he was one of those from Wisconsin. But all large medical centers will have someone who is administering botulinum toxins, and then bracing. So stretching can be combined with a device which gives a static stretch. I'm going to throw out one company is called Dynasplint, which is a device that can be attached to the leg and gradually over time by sort of turning a screw can go into a more and more extended position to give a prolonged stretch. So usually it's a combination, but positioning is very important to try to reduce that sort of muscle tightness where the knees are tight in flexion.
And I think that probably answers Anne's question as well. Anne had asked what can be done after leg is already affected by a contracture and won't straighten out all the way. So very similar topic there. So our next question is from Debbie, who asked, can the attendees obtain tonight's PowerPoint slides? Are you comfortable with those being shared, Dr. Brown?
Absolutely, absolutely.
Okay. In that case, Debbie, you can reply to your registration email and we'll get a copy of that to you. She says she would like the copies for her personal MS reference binder because this has been a great program this evening.
Thank you very much.
All right. And another question, Debbie asks, how can one conclude that spasticity is what is causing frequent urination? Can a urodynamics test provide the proof?
Yeah, that's a good suggestion. So when we're talking about spasticity, we're usually talking about striated muscles. And I don't want to get too complicated, but the biceps, that is striated muscle. And spasticity there we can feel as this overactive muscle. But smooth muscle is in the intestines, and smooth muscle is in the lining of the bladder wall, or the detrusor muscle, that's smooth muscle. So that can be spastic as well. And then you have a overactive bladder that doesn't relax properly. And really a urodynamic study is probably the best way to identify that. So talk to your MS specialist, and they might refer you to a urologist for further assessment in that situation, or they might say, let's go ahead and let's try some management strategies to treat that. I do want to just mention that quite often spasticity and overactive bladder go together, or on the other hand, it can be spasticity and urinary retention from a tight bladder outlet, as was mentioned in another person's question.
All right, thank you. And our next question is from Jackie. Jackie says, I have random spasms of the feet, usually in the evening or night. I started taking a 400 milligram magnesium capsule at dinner time, and it seems to dramatically reduce the spasms. Is this a known treatment, and is it safe to continue daily?
Well, I'm really glad you brought that up, Jackie, because there's sort of two levels to this that I want to address. The first one, I just want to say I like magnesium. Magnesium is a nice holistic way to relax muscles that's been around for a long time. And we do regard it as safe, but just that you ought to be a little careful how you dose magnesium, because, you know, magnesium is also a laxative. So if you take too much, it's going to upset the bowels. And so we sort of advise people to slowly go up on magnesium to avoid that. But it is a good thing to consider. Now, that brings us to the second part of this, which is, you know, if this is working, does that mean that I'm having spasms? Well, in the legs, when you have jerking muscles, it can be spasms, it can be spasticity, it can be cramps, which one of the first question I think we got today is, you know, are spasms and cramps the same thing? They're not. And then the other thing it can be restless legs. So how would I distinguish that? Well, with cramps, there's usually tightening up of one muscle, and you're less likely to see the whole limb jerking with that. And cramps are usually quite painful. spasms might not be as painful as a cramp, okay? With spasms, typically it's the whole muscle, not just part of the muscle that's tightening up. There might be more movement of the joint, and then it's often multiple muscles as well. Spasticity tends to be on a larger scale. And then with restless legs, there's sort of more this irritability, this sort of uncomfortable feeling in the legs. They don't want to relax. They're sort of jumpy. They can do some kicking, but they would maybe not be spasming as much as you are sort of voluntarily kicking them out to try to relieve this muscle tension that happens with restless leg syndrome. Now, magnesium could potentially treat all three of those. Isn't that great? So, you know, if magnesium is working, that's wonderful. It's one of our safest approaches. Just watch the effect on your GI tract.
All right, our next question is anonymous, and it's, would it be harmful for an MS patient to take their baclofen this way, all 3 tablets at night as opposed to 3 times a day as instructed?
Well, check with your doctor on that, because I can't give specific advice. I can say, though, that there are situations where we do treat in that manner. So, for example, someone who's not bothered by spasticity during the day, but they're bothered a lot at night, that might be a scenario where we only treat with baclofen at night. And then if a low dose doesn't work, we would go higher. You know, there are limits to how high you can go at 1 dose with baclofen, but that's not uncommon that we'll have someone who only takes baclofen at night. And it could be, baclofen is usually 10 milligrams or 20 milligrams. It could conceivably be as high as 3 20 milligram tablets at night. But for an individual, you know, check with your provider, because they very well might have different advice.
All right, Deborah would like to know, does spasticity make your thighs continuously sore?
It certainly can. Yeah, that's one of the ways that spasticity can be painful. So it can be painful when you're having spasms, but it can also be painful from that increased muscle tone, that your legs are just not relaxed. And that's a really uncomfortable feeling, to just have your muscles being tight all the time. And I wish that I could have set up a video to show you when I do botulinum toxin injections. I'll put an electrified needle into the muscle so that I can hear the muscle activity and know I'm in the right place to inject the botulinum toxin. Well, we're listening to the muscle activity, and in a normal relaxed muscle, it'll actually be almost completely quiet. And in a spastic muscle, it'll be making this noisy sort of clicking sound that sounds sort of like an engine rumbling. So that's just all those muscle fibers that are not relaxed, and that's going to be painful over time because the muscles can get sort of sore, and they can even become inflamed from that.
That's cool that you can do that.
That's what we do.
David asked, wouldn't using orthotics be the opposite of stretching calf muscles?
Great question, David. Well, so there's a yin and a yang, right? So when we're stretching one muscle group, we are relaxing the other muscle, the opposing or antagonistic muscles. Okay, so let's take the knees, for example. We had someone, and I'm sorry, I'm forgetting your name, but one of our listeners said that they were dealing with knee flexion spasms and maybe knee flexion contracture. So there's tight knee flexors, and we would be stretching that out potentially with a brace. At the same time, we're sort of putting the opposing muscles, in this case, it would be the quadriceps on top of the thigh, in a relatively relaxed position that is relative to their tight hamstrings position. That is a potential concern, but when we're dealing with a contracture, we're definitely more worried about the tight muscles, not the looser muscles. But we don't usually have those braces applied 24 hours a day. That would be very unusual. We might put it on for 30 minutes and we gradually increase the time to a couple hours. And then maybe we gradually work up to where the person can apply the brace overnight. But we move slowly again because we want to avoid pain, we want to avoid blisters and other problems that can happen with bracing.
Dr. Brown, I want to respect your time. We are at our usual stopping point, but we still have a lot of questions. Are you able to stay for a little bit longer?
Yes, I can, Casey.
Awesome. Thank you so much. We had a large crowd tonight because, like we said, this is a very important topic. All right. David would like to know, can you get acclimated to baclofen or the other treatments, reducing their efficacy over time?
Yes, you can, and it's possible that we have to go up to a higher dose. That would be that we have a medical term for that process of acclimatization. We call it augmentation, where we have to over time go to a higher dose. But on the other hand, sometimes initially someone has poor tolerance for a dose. But if they can stick with it, they might find over time that they also sort of find that their tolerability for the drug goes up. So it can work both ways. But it is true that sometimes we have to gradually go to a higher dose to achieve adequate relief of spasticity. Or perhaps we switch to a different medication or combine medications.
So next we have a couple of questions about sort of an is this spasticity question. There are two of them. Michelle asked, she said she's noticing stiffness in her ankle, making it uncomfortable when she goes down steps and sometimes when walking, and wants to know, is that spasticity? And Christy says that she's got she's getting cramping in her calves and it makes her shin hurt like she has shin splints, and wants to know, is that spasticity?
Well, potentially yes and yes. You know, they both could be spasticity. The stiffness in the ankle going downstairs, that's an interesting one, because when people go upstairs, they're usually getting more stretching of their calf muscles because you're sort of bending them as you go. Going downstairs, we're sort of flexing our foot down, and that tends to be the more relaxed position for the calf muscles. But potentially that could be stiffness. That stiffness rather could be spasticity. And then the cramping in the calves, absolutely. You know, cramping, just that feeling of tightness. It can vary. It can come repeatedly, or it can be continuous. Very definitely that could be spasticity. And one way to sort of distinguish cramps from spasticity, and I said this earlier, is that with cramps, it tends to be feeling like one portion of the muscle is really tightening up and, quite painful and often quite brief, and you have to sort of knead it out. You have to sort of massage to get that to relax. In that situation, magnesium or other electrolytes might be helpful to reduce that, and stretching is still important. And then with if it's spasticity, it tends to be the whole calf, maybe involving multiple muscles, because there are at least 3 different muscle groups in the calves that are tightening up, causing cramping. And we'd be sort of looking for the foot to go into a plantar flexed position. So I'm not flexible enough to bring my leg up, but I think you know what I mean, that the foot is sort of going down relative to the long axis as opposed to being up.
All right. Our next question is Jack says, you mentioned 2 spasticity clinics. Can you say again where those clinics were?
Okay. All right. Well, one of them is at, it's in Milwaukee, University of Wisconsin, Dr. Ketchum. The other one, I know it's on the East Coast, and I am thinking it might be Johns Hopkins, but I'm sorry, I'm not sure what the other one is. But I would just say that there are doctors with expertise at any large medical institution. Spasticity is a common problem. There's commonality with stroke and spinal cord injury, and you can access medical expertise without needing to travel to another state, certainly. And if it's possible that in a more rural setting there might not be a doctor who has that degree of experience with spasticity to want to manage it, but in larger settings. And since it's so common in MS, most MS centers will have an established process of referring patients to someone with spasticity management expertise. And most MS doctors and nurse practitioners have experience in managing spasticity on their own.
Our next question is from Joey, who asked, can spasticity manifest in the nose and ear areas?
In the nose, boy, that would be, there's not a lot of muscle in the nose. And even in the facial muscles, there's something called hemifacial spasm. I should mention that, where people can have spasming of the muscles, the orbicularis oculi, the muscles of the eyelid, and they're sort of, having these irritating muscle fasciculations in their face, and they can have their cheek muscles sort of grimacing. But the nose itself, not so much. Spasticity in the ear, well, interestingly, there is a muscle in the inner ear. I think it's called the stapedius, and it is possible to have spasticity of that, which I think would have an impact on your sensitivity to noise. But that's something that we don't encounter often in multiple sclerosis.
Our next question, Jody asks, can you confirm that these are symptoms of spasticity? Hard to move at night, bladder issues, not making it to the toilet in time, gait issues, muscle tightness in back and legs.
Well, it sounds like it, Jody. I mean, what you're describing, that sounds like there's some element of spasticity there. But I can't confirm anything for you, really, because you need someone who knows you, someone who can examine you. An examination goes a long way. And in today's era of virtual visits, unfortunately, one of the casualties of that is we can't do a very good job evaluating spasticity. All we can do basically is watch someone try to walk or move and sort of observe whether they're having muscle spasms, but we can't really assess muscle tone. So seeing a MS provider who can give you a good examination would really be the way to go to sort that out. But the symptoms that you're describing are concerning for spasticity, absolutely.
Our next question is from Christy, who asks, would duloxetine help? I've been taking gabapentin, but not routinely. So glad to know I could be having rebound spasticity.
Yeah. Duloxetine is not in our sort of treatment algorithm. Duloxetine is an antidepressant. It's also approved for anxiety. It's also approved for pain of a musculoskeletal nature. It's approved for fibromyalgia. I could go on. But it's not approved for spasticity, and duloxetine probably isn't very effective for spasticity management. So that's not a drug that we would use for spasticity. We would use that in some situations for nerve pain, however, because it is approved also for diabetic neuropathy, which is nice.
Our next question is from Teresa, who says, not sure this is the right term for it, but asks what causes sudden tremors, which she describes. She says, while I'm resting, all of a sudden my forearm will move up, and once it hit me in the head. Also, I'm very flexible and stretch all day. The gabapentin helps with the MS hugs and surface nerve pain, for anyone who is wondering.
Okay, a couple of possibilities there. One is that, yes, it could be that it's a sign of spasticity, and for whatever reason, it's only intermittent and maybe paradoxical that you're getting that, but that can be a sign of spasticity. But also there's the possibility that you have something called myoclonus, where people can suddenly have jerking of their limbs, and it just comes on, and it can be once a day. Perhaps some of you have had the experience of you're falling asleep at night and suddenly you'll just get this jerk and your body sort of grimaces and then it relaxes. And that's something else. Myoclonus is not spasticity. So that one you would want to discuss with your primary doctor, your MS doctor, or if you see someone in sleep medicine, they could assess that. But when you mentioned that, I think you said that it was happening at night, it does make me wonder about it being myoclonic jerks, which if they're not bothersome, they don't necessarily need to be treated. If they're recurrent, then there are medications used for that. And it's great that you're stretching, because stretching is the first step in managing that as well.
Our next question is from Joey, who asks, can spasms manifest in the pelvic floor area?
Yes, they can. So spasms and spasticity can cause the hips to come together. The hip adduction will cause the knees to sort of lock in place. That increased muscle tone makes it hard to spread the legs apart for changing clothes or toileting. So that can definitely happen. You can also have spasticity that causes the hips to flex up, so that someone lying down would have a hard time getting their hips to straighten out. And then, within the internal pelvic structures, we talked about the sphincters, you can have spasticity there as well. Spasticity of the bladder muscle, the detrusor, and then opposing spasticity of the bladder outlet or the bladder sphincter and the anal sphincter as well.
All right, a couple of questions, both related. An anonymous attendee wants to know, can chiropractic help with spasticity? And Anita asked if massage can help with spasticity.
I would say yes and yes. Chiropractors, we regard them as a valued ally to what we do, but we do have different approaches. But I think there are certain chiropractic techniques that might be helpful. I certainly don't want to advise against chiropractic care, but I would say, best to sort of run this by your MS doctor, if you have one first, because they can sort of give you advice. And we don't usually refer patients to chiropractors for spasticity. We would be more likely to refer to a physical therapist for that. Now, massage, okay, I think that's very useful. And massage can be done by a massage therapist. It can be done by a family member. It can be done by a physical therapist. So massage is really helpful because of that overactive muscle tone. Massage can really help to loosen up muscles. I highly recommend that.
Okay, I see we're coming up on the half an hour here, so let me just pick one or two last questions to get in. Andrea asks, there's a lot of research in MS medications. Are they looking for different or better ways to treat spasticity?
Absolutely. So like across the country, there's work on spasticity right now. And a lot of that is going on in MS. Our own center, we're looking at two different approaches to spasticity. And I won't get into that today, but just to let you know, there are oral and other forms of anti-spasticity medication that are being studied. And check with your MS provider and see if their institution has an anti-spasticity trial. You can go on clinicaltrials.gov and find resources there, studies. You can search for MS and spasticity and see what studies are available and what centers are engaged in that. And I really encourage everyone who has any interest in research to look into that, because that's, it takes a team effort to make it happen.
Thank you. All right. Glover wanted you to know, he said, Dr. Brown, this was an excellent presentation with great information and for me an inspiration as well.
Thank you so much.
And David asked, last question, I promise, he said, I see this is recording. Where can we get a copy of this webinar? Well, let me tell you a little bit about that as we close up. If you missed any part of this presentation or would just like to watch it again, it will be available on the MS Focus Facebook page today and on our YouTube channel within a couple of weeks. You will get a follow-up email from the foundation tomorrow that will tell you a little bit more about where you can access that. Also, if you're interested in learning more about our upcoming programs, you can reply to your registration email for today, and we'll tell you how to sign up for our newsletter to learn about upcoming events. Our next teleconference will actually be next Monday on the 27th, and the topic will be why lab work matters. Doctor of Pharmacy Adrian DeBerry will be talking about the different lab monitoring used for MS and its treatments and why those labs are so important. So if you want to know why they keep poking you for more blood, Dr. DeBerry is going to explain. As you leave the conference today, a survey will appear on your screen. We ask that you please take a moment to give us your feedback on this program and your suggestions for future topics, so we can be sure to provide you the best programs possible, what you are really interested in. So our sincere thanks to all of you attendees for coming, for being engaged, for bringing your questions. We appreciate that so much. And especially our thanks to you, Dr. Ted Brown. Thank you so much for all the time that you spent, not just preparing and sharing this information, but taking so many questions, staying with us for so long. We really appreciate you.
My pleasure, Casey, and thank you everyone for all the great questions and your attention.
Well, thank you everyone. Have a wonderful evening.